Welcome back, and if you're new to the channel, I'm happy to see you here. So, have you ever had a patient who suddenly seemed confused, drowsy, or just not quite right, and you couldn't figure out why? What if the problem wasn't infection or medication, but low sodium? That's today's topic, hyponatremia. Hyponatremia is one of the most common and overlooked electrolyte imbalances nurses encounter, and if you miss the early signs, the results can be life-threatening. From subtle mental status changes to full-blown seizures, hyponatremia can escalate fast, and it's our job as nurses to catch it before it's too late. But here's the challenge. The symptoms often mimic other conditions, confusion, fatigue. That's why knowing how and when to suspect hyponatremia can make the difference between early intervention and critical deterioration. In this video, we discuss why hyponatremia is such an important condition for nurses to recognize, how it presents in real-life patients, and what actions you need to take to protect your patient's brain, heart, and life. Hyponatremia is defined as a serum sodium level less than 135 milliequivalents per liter. The primary effects are on the brain, neuromuscular activity, and water balance. But before we get too far into our discussion about hyponatremia, I would like to address fluid imbalances in general and review some key foundational points. Fluid and body compartments to review. Terms and definitions to familiarize yourself with and know. A quick review. Body water represents about 60% of the total body weight in the average adult. Water is distributed among the three compartments. 1. Intracellular, which means within the cells. 2. Intravascular, which is within the blood vessels. And 3. Interstitial, within the tissue spaces. Now, fluids in the blood and tissue spaces are outside of the cells, and they are referred to as extracellular fluid. All patients are at risk for some degree of fluid imbalance because many health problems can disrupt fluid intake or output. Lesson overview. In today's video, we're going to break down exactly why hyponatremia is an essential condition to recognize as a nurse. We'll cover what hyponatremia is and why it matters, common causes and risk factors, key signs and symptoms to watch for, nursing assessments and priority actions, and how to support and educate your patients at risk. The more you understand about fluid and electrolyte balance, the more prepared you'll be at the bedside and on your exams. What is hyponatremia? A normal sodium range is 135 to 145 milliequivalents per liter. Hyponatremia is a condition where serum sodium levels fall below 135 milliequivalents. Sodium plays a vital role in nerve function, fluid balance, and muscle contraction, and low sodium levels in the body can lead to swelling of the cells, especially in the brain, which may cause serious neurological symptoms. There are 3 types of body fluid volume imbalances associated with hyponatremia. We have hypovolemic, or decreased fluid volume, euvolemic, or normal body fluid volume, and hypervolemic, increased body fluid volume. In order to correct the underlying cause of hyponatremia, it's important to identify the type of fluid body imbalance associated with the hyponatremic state. With hypovolemic, associated conditions include diuretics, emesis, diarrhea, gastric suction, and burns. In euvolemic, normal body fluid hyponatremia, associated conditions include SIADH, pain, postoperative state, and cortisol deficiency. And then with hypervolemic, increased body fluid associated conditions include heart failure, cirrhosis of the liver, acute and chronic renal failure. So fluid imbalances can occur in any setting. These imbalances can occur in healthy people because of changes in fluid intake or fluid output. Imbalances are usually mild and can be easily corrected. Next, we have body involvement and function of sodium. The 2 most important functions of sodium include water balance and neuromuscular activity. In terms of neuromuscular, sodium is involved in the transmission and conduction of nerve impulses, also called the sodium pump. For body fluids, sodium is largely responsible for the osmolality of vascular fluids and regulation of body fluids. With cellular involvement, the sodium pump action is where sodium shifts into the cells as potassium shifts out of the cells. This occurs repeatedly to maintain water balance and neuromuscular activity. With acid-base levels, sodium assists in the regulation of this balance. Sodium combines readily with chloride or bicarbonate to regulate the acid-base balance of the body. Now, it's important to note the central nervous system, or CNS, is the most sensitive to decreased sodium levels. When sodium drops too low, excess water moves into the cerebral tissues. Cells begin to swell, which can result in neurological changes and increased ICP, or intracranial pressure. General causes of hyponatremia. Hyponatremia can occur due to either sodium loss or excess water in the body. Some common causes include the use of diuretics. Diuretics can decrease serum sodium and chloride levels. Note, with advanced renal disorders, the tubules do not respond to ADH, therefore there's a loss of sodium and water. This is known as salt-wasting kidney disease. Heart failure or liver disease, where we have a fluid overload. Extracellular fluid is increased, which then causes dilution of the serum sodium. We have hormonal influences or excess release of SiADH, where this promotes water reabsorption, and then we have sodium dilution. I'll talk more about this syndrome on the following slides. Excessive water intake, also called polydipsia. You can have dietary changes. Drinking large amounts of water will dilute extracellular fluid, leading to hyponatremia. You can have a low sodium intake over several months. This can lead to hyponatremia. If hospitalized, administration of continuous IV fluids such as D5W can dilute extracellular fluid, which can lead to water intoxication. GI losses such as vomiting and diarrhea, gastric suction, and burns and wounds. So with this type of injury, there's great quantities of sodium and chloride that get lost from the wound, essentially oozing from the burned surface or wound areas. This loss can also occur with increased environmental temperatures, diaphoresis, and fever. Imbalances can become severe, and it's important to know that certain patient populations are at a greater risk for developing electrolyte imbalances. People at the greatest risk for severe imbalance are older patients, or patients with chronic kidney disease or endocrine disorders, and patients who are taking medications that alter fluid and electrolyte balance. Older adults are at risk for electrolyte imbalances as a result of age-related organ changes, and they're more likely to be taking medications that affect fluid and electrolyte balance overall. What is SiADH? SiADH is characterized by the excessive release of ADH, a hormone that regulates water balance by controlling how much water the kidneys absorb. In SiADH, the kidneys retain too much water, thus diluting the blood and leading to low sodium levels, which give us hyponatremia. Think excessive ADH release equals water retention, which then equals sodium dilution. This condition is often diagnosed when a person has a low blood sodium, low blood osmolality or concentration, and an inappropriately high urine osmolality and sodium levels. Signs and symptoms of hyponatremia. The severity of clinical findings depends on the serum sodium level and how rapid with which the reduction of sodium occurred. Some common signs of hyponatremia include the following. For central nervous system involvement, headache or apprehension can occur. Confusion, lethargy. A sudden onset of acute confusion or increased confusion is often seen in older adults who have low sodium levels. It's important to note if there's a rapid drop in sodium, a patient is at risk for cerebral edema. muscle weakness and cramps, GI symptoms such as nausea and vomiting, seizures. When sodium levels become extremely low, seizures, coma, and death can occur. A rapid drop in sodium is a risk for cerebral edema and ICP, intracranial pressure. Decreased deep tendon reflexes, abdominal cramping, skin changes, dry, pale skin, and lastly, cardiac abnormalities. A patient may present with tachycardia and hypotension. Treatment and medical management. Overall, interventions with drug therapy and nutrition therapy are used to restore serum sodium levels back to normal. Treatment depends on the underlying severity of the hyponatremic state and how quickly serum sodium levels had dropped. Nursing care priorities are assessing a patient's response to therapy and preventing hyponatremia and fluid overload. You want to monitor patients' eyes and nose, monitor serum sodium levels, increase oral sodium intake, and administer IV saline solution. If a serum sodium is less than 115 milliequivalents, small volume infusion of hypertonic saline 3% solution is advised. When giving the saline solution, the patient should be closely monitored for fluid overload and pulmonary edema, as well as taking seizure precautions if the hyponatremia is severe. As far as a nursing diagnosis, imbalanced nutrition, less than body requirements related to poor intake of foods high in sodium. Electrolyte imbalances. On this slide, I have a side-by-side comparison of sodium imbalances, hyponatremia and hypernatremia. This slide gives you the disorder, common causes, signs and symptoms, and treatment modalities for each imbalance. With fluid imbalances, the state of the imbalance involves either a deficit or an excess in overall fluid volume, or there's an alteration in the distribution among the fluid compartments within the body. Nurse assessment and role. As a bedside nurse, you want to monitor labs, be alert when the serum sodium levels are trending low or drop below 135 milliequivalents, assess patient risk factors. As the bedside nurse, you want to ask yourself these questions. Is the patient on diuretics? Is the patient receiving IV fluids? And are they showing signs of fluid overload? Recognize mental status changes, confusion, drowsiness, or irritability may be early signs of cerebral edema. Report promptly. Early notification to the provider is key and can prevent patient deterioration. And lastly, educate your patient. Teach at-risk patients, especially those on fluid restrictions, diuretics, or with heart failure, about the importance of electrolyte balance. Final thoughts. Hyponatremia may start with something as small as a headache, but if ignored, it can end with a seizure or cardiac arrest. That's why knowing how to recognize it and respond quickly can make all the difference. Have you encountered hyponatremia during clinicals or at work? Share your experience in the comments below. I'd love to hear from you. Thank you so much for watching. If this video helped, give a thumbs up, hit subscribe, and turn on the notifications. We'll see you on the next one.